Resume.
Awesome, thank you. So m- my name is Tiffany, and this is Kristen. So we're from Rain Therapy Collective, and we're presenting today, and I'm going to share my screen um, so that we have our PowerPoint. Oops, should have shared it already presenting. Okay, quick vulnerable question. Can you guys just see the slides, not our notes?
We can just see the slides, yes.
Awesome. I realized that when we practiced this, we were like already on presenter mode, and we actually didn't see what it looks like in the audience, and that would be really embarrassing. So, okay, we're good. Um, um, so yeah, we are going to be presenting on neurodiversity affirming speech therapy. And the way we've structured this presentation is very neurodivergent. And so we're like so excited to be in a space where like that's okay and accepted, because this is a huge topic. And there's a lot of areas in speech therapy, but we definitely have like areas that like are our special interests. And so we structured them so that instead of them being at the end, because I think for both of us, like our areas tend to be like towards the end of most presentations, but then there's never enough time and then it's disappointing. So we structured them so that at the beginning, which is like a little bit weird, but like that's because we want to talk about them. Um, um, and they're a little bit longer. So we're happy to talk about our special interests. We're also happy to talk generally as well. But just a little note there. You'll definitely notice that. How do I make this a little bit bigger? Okay, cool. All right, so yes, so I'm Tiffani Kittilstved. One disclosure I want to make is, in case you haven't noticed, I have a stutter. And so if at any point you have trouble understanding something I say, just tell me, and I'm happy to repeat it. I'm actually good at that because I stutter. But yeah, and then Kristen and I both are the founders and owners and speech therapists at Rain Therapy Collective, which is a private practice focused on neurodiversity affirming speech therapy in Seattle, in Queen Anne. So yeah.
So as neurodiversity affirming SLPs, we're trying to shift from changing communication to supporting authentic expression through genuine connection. So our goal is to honor each person's unique style, strengths, seeing their communication as differences as valuable and enriching. Our job is to create safe spaces that foster real connection, respect all ways of being. And ultimately, as speech therapists, we want to focus on helping people engage and participate meaningfully in their communities while celebrating their neurodiverse communication, not trying to fix it.
Yeah, so we do that from a social model of disability. So I'm sure everyone's a little bit familiar with this, but in our field especially, all of the origins are really heavy in like medical model. And so our field, I think, is slowly, maybe more slowly than counseling, I'm not sure, switching to that social model. And depending on which area you focus on, like which area of speech therapy you focus on, some are having a harder time switching than others. The area I focus on is stuttering, and I think in stuttering we've actually been leading this push towards thinking about our work differently. And so how this like shows up in speech therapy is that instead of thinking about disability and communication disabilities as something that is like the problem that's within a person, or a disorder is the language like that people use predominantly still. It's that the only thing that's a barrier is the ways, well, the barriers are that come from the ways that society is disabling. And so the ways that internalized ableism is within people, the ways that that's like built into structures, inaccessibility is built in structures, that's what's really disabling of someone. And so our work is shifting to where instead of making the person change and sound different or talk differently or show up differently, we're trying to help empower them to advocate for themselves, to ask for accommodations, and to be able to show up how they are without having to accommodate neurotypical ideas. And so the emphasis is just on helping the person navigate this world. And another thing that I think is really important to state is using a disability justice lens. You have to, if you have a disability justice lens, consider and hold as the tenet of it intersectionality. And so, you have to recognize that ableism disproportionately affects people who are marginalized in other ways. And this idea of like, if someone is a person of color and they're disabled, then they're more likely to experience, they're more likely to experience that compounded oppression of being an intersectional body. And so I think that's just an important thing to kind of make a comment on. When we're working with clients, we should be thinking about them as a whole person and how their disability impacts them, but how it also impacts them within this intersectional framework. That's what disability justice really is.
So within that, the speech therapy scope of practice is really wide. And so we tried to touch on our special interests, which mine would be feeding. And then Tiffani has stuttering. And so the rest is very much a brief overview of all the areas. So if you have any questions, feel free to just like jump in.
Yeah, the way we're going to structure this is we're doing like each area. And so if you have a question about a specific area, it's okay to wait to the end, but it's also okay to just jump in and we can talk about that area while we're talking about it. So that's totally okay.
So I'm going to talk about feeding therapy and introduce you to these 10 myths related to eating as a whole. So the first myth is that eating is your number one priority, which in fact it is not. Breathing is number one. Like when you have a head cold, it makes it harder to eat and you have to breathe. Not following your head is the next one. So you need postural stability while you eat, so your core gets activated. And you also want to protect your brain so you don't fall off your chair while you're eating. The stability frees up the motor brain to focus on the task of eating rather than not falling your head, and it allows for range of motion in the jaw, like for munching and chewing. And then the third priority is in fact eating. And then myth number 2 is that eating is instinctive. This is not true. Eating is learned. There's, I think, like 25, 30 steps to eating a new food. And then the third myth is that eating is easy. Eating is actually one of the hardest tasks we can do because the only thing that we do as humans that involves all 7 areas of the brain, all 7 areas of human function, and then, So eating is actually the most difficult human task. So when someone doesn't eat, there are 7 different areas of human function that's involved. So when they don't eat, the feeding difference that you see is literally the tip of the iceberg. It's a sign that they're being impacted in all 7 areas of human function. Eating is the only thing that takes every organ, your heart, your lungs, skeleton, hormones. It's the only thing that we do that involves your liver, your pancreas, your kidneys. It involves both exterior parts of your body, your arms, your legs, your head, and then the inside of your body, which is like the movement of your esophagus, your GI tract, all your sphincter muscles. And then it also involves all 8 senses of your body. And it involves your learning style. So your capacity and history, it's supposed to learn that eating is fun, enjoyable, and it's supposed to make you feel good. If the body doesn't work, you learn that eating doesn't work, and so it's a hard choice. It doesn't feel good. You don't want to do it. You want to avoid it. It also involves developmental transitions. We know there's certain areas in development when eating gets better and eating gets worse. It involves your nutritional status. If you're not getting adequate calories, you can have poor strength and endurance for eating. And if you're not getting the right vitamins and minerals, you won't have good appetite or be able to absorb your calories. And then environment is involved. It's making eating an issue better or worse, but doesn't usually cause the problem. And this, oops, wrong way. So myth number 4 is that eating is two-step process. You sit down, you eat. Eating can be 25 or 32 steps depending on eating differences. And then myth number 5 is that it's not okay to play with your food. The best tool in learning is actually wearing your food. It's part of the process of like learning to eat, experiencing the touch of your food on your body, like engaging as many sensory experience as possible in food is very helpful. And then the 6th myth is if a child is hungry enough, they will eat, and they will not starve themselves. This is unfortunately not true, as children will often starve themselves over forcing themselves to eat. Number 7 is that people older than 16 to 18 months of age should be eating every 2.5 to 3 hours, rather than only needing to eat 3 times a day. And then myth number 8 is that children who eat either have a behavioral or an organic problem. So eating issues are often more complicated. They can be medical or environmental. And in only 10% of the cases when children don't eat is purely a medical issue where we can do like a medicine or a surgery or procedure to like fix their eating. In only 10% of the cases is it environmental, and then eating issues involve both physical and environmental challenges. Myth number 9 is that certain foods are eaten only at a specific time of the day, and only certain foods are healthy for you. Food is just food. The labels we give food are often cultural. Feeding therapy focuses on offering a variety of foods. So you ideally want to have a protein, a starch, a fruit, or a vegetable at every meal or snack, regardless of if the person is going to eat them or not. And then myth number 10 is that meal times are a proper social occasion. You're to mind your manners at all meals. Meals are learning occasions, and our best learning experiences are interactive. So if they're not learning to eat, we have to teach them to eat. So knowing if they're a good candidate for feeding therapy, there's a history of ongoing choking, gagging, or coughing during meals, history of a traumatic choking incident, history of eating and breathing difficulties. There's an aversion or avoidance of all foods in a specific group or texture, like if they avoid all fruits or all vegetables or all like wet texture foods. Those are really common. They have a food range of less than 20 foods, and if foods are being dropped, so oftentimes neurodivergent folks hyper focus on food, and so the difference is that sometimes they'll hyper focus and then come back, but if you have feeding differences, you often can't come back to it, so you burn yourself out. Family is often fighting about food, and then parents repeatedly report that the child is difficult or having a really hard time eating.
We have two questions in the chat. Is now okay time?
Yeah.
So one of them is, how do the feeding and swallowing differ from the work that OTs do with it? And then also, have you worked with any intellectually disabled or developmentally disabled clients experiencing ARFID?
So the first one is differentiating between this and OT. Is that correct? Okay, so there's a lot of overlap. In an ideal situation, someone would be seeing me and an OT, because there's often a lot of intersectionality between like the sensory processing of food as well as the oral motor side of food. And so speech therapy has a lot of work and practice with teaching a rotary chew, which is what we do as adults, or should do as adults, which is we use our jaw and create that circular motion to break down food. And also we would help teach them what to do with your tongue and like how to coordinate those movements. And so that would be a lot of my focus, while also including that sensory input. While OT's focus would be more on the sensory side. And then because I mean, you can't not have a rotary chew. You can't not chew when you're eating. And so they would help support that, but wouldn't necessarily have the same tools. And then, yeah, I've worked with a lot of clients who have intellectual disabilities and ARFID. There's often, right now, an overdiagnosis of ARFID. From what I understand, ARFID is linked to a lot of like body image issues, where someone can have ARFID and also have another diagnosis that I'm trying to think of what I'm trying to say. So with ARFID, there's often a sensory side or motor side that can be missed with that diagnosis. I've had a few clients who were just diagnosed with ARFID, sent to inpatient and like force fed, which was really harmful to them, to the point where they disassociated, don't remember those few weeks of being inpatient. Because really the core thing that was going on was the sensory side of food and not having a rotary chew. And so when you don't have a rotary chew, you have a negative experience eating a food, then it's linked to that. And so then you get inherently scared, don't want to try new foods because you have that choking, that negative experience of like, this food slipped away from me, I gagged, food is bad. And so that's often missed. Hopefully that was enough information. If you have any more questions.
Thank you.
So the focus on feeding therapy is a lot of building trust and a sense of autonomy around food through connection and exploration. So instead of pressuring them to eat, we support their sensory preferences and validate their experience and create a safe space for food-based play and learning. And so this is teaching about how to change a food in a way that meets your sensory needs. Some people really like foods with very mild to no flavor, or some people really like big, bold flavors. And so it's teaching autonomy while also working on the oral motor side. So working on tongue movement and jaw movement. And then in therapy talks about exploring food in like a very low pressure way, a lot of opportunities to say no or walk away. And then using individualized strengths-based strategies to help them feel more confident and control during food.
Okay, yeah. So we're gonna pause for just a second before we move on to the next big area. We're gonna have a big pivot. And so does anyone have questions for Kristen about feeding therapy or about swallowing or feeding disabilities before we kind of switch to stuttering? I never know how long to wait. I feel like it's always like, it always feels like when you're waiting in silence, it always feels like it takes like longer than it is. And so I don't want to rush. Okay, go ahead.
Yeah, I have a question if that's okay.
Yes.
So I think I've seen an increasing like awareness and understanding for ARFID that didn't exist even a handful of years ago. And as families are looking for neurodiversity affirming support to address ARFID for the domains that you talked about, the sort of sensory piece of it, the anxiety or trauma that may have occurred from being in situations where you couldn't navigate the food in a safe way, and then also for the oral motor, like the chew, the rotary chew, all of those things that you know far better than I do. How would you advise guiding people to look for providers who are going to be knowledgeable and who are going to approach it in a neurodiversity affirming way, as opposed to, as you kind of said, add traumatic experiences on top of already difficult feeding experiences because they're coming at it from a non-affirming way? What should people ask? What should they be looking for?
So from my experience, acknowledging that the client needs a sense of autonomy is really important. So there's a few different therapy approaches that essentially have kids do a very structured therapy approach. And so they're essentially forced to engage in all the foods that the therapist brings out. And they're supposed to stay at the table. And so I think when there's such a fear of food, that kids and people should be able to walk away from the table and not have to engage in such a structured therapy when it's not appropriate. And so it's that sense of forcing someone to have to engage in the therapy the way that the therapist wants to engage, and finding someone who's able to meet them where they're at. I mean, I have kids who they are so afraid of food, they'll literally run us out of the room when a lunch box is brought out. And so being able to engage in food just from a purely play perspective can be helpful because that's where they're at. Or being able to engage in food with food while they're playing with like a dollhouse, because sitting at the table is too much of a demand because they know that's where they are required to eat, when I'm never going to make someone eat. And so just having that fluidity and knowing, where they're at.
Thank you.
That was helpful enough.
I had a quick question on that. I was working a case last year where my client was really struggling, especially at school with ARFID, and everything you said totally checked out. I think that the school faculty just wasn't really aware of the sensory component going on to it and the table, right?
Mm-hmm.
I I was wondering if you would recommend maybe just varying up that environment, but keeping some of that like very gentle like steps of exposure therapy, like having like a I don't know, array of different foods that the client could maybe choose to engage or disengage with. And yeah, just trying it outside of an environment that just doesn't feel very, like you said, play-based.
Yeah, so school is a really, really hard environment because when you're at lunchtime, you're surrounded by like 20, 30 other kids. And
Yeah.
so they're all bringing their lunches that maybe the kid hasn't been exposed to. There's also a lot of smells and so much sensory input at lunchtime. And so a lot of times offering like prioritized seating. So sometimes having them sit at the end of a table or close to a door, so that way they have that exit if need be. And then there's also less sensory input. And so you don't have to look at all of the lunches around you. You don't have to engage if you don't want to. You can look away, you can wear headphones. Sometimes offering kids like 5-10 minutes before lunch so they can go eat and then come to lunch with everyone else. So that way there's not that separation, but they still have time to eat.
Yeah.
And not as much of a fight or flight situation.
Yeah. No, thank you.
Yeah.
Any other questions before we pivot here? No? Okay. You do, it's okay. We'll talk about them at the end as well. So, all right. So, very, very severe pivot here. So we're going to talk about stuttering. Stuttering is a very different area than feeding therapy. But again, neurodivergence, it's our two special interests. So, yeah. So a little very brief intro on what stuttering is, what it isn't. So first of all, I feel like I'm having to say this, explain this differentiation more recently than I have before, but stuttering and the word stammering are the same thing. So I think there's like some internalized stutter phobia, some internalized ableism around this, where I'm hearing, especially fluent people who don't stutter, try to differentiate between what stuttering and stammering are, as saying like stuttering is what you do, stammering is what I do. Not true. So if you want to have that distinction, stuttering is a disability. And when someone who is fluent, someone who doesn't stutter, has a moment of stuttering, they're not really stuttering. It's just a casual way to talk about it, unfortunately, in our society. So they're also not stammering, but they're having what's called the typical disfluency. Again, typical, already entrenched in neurotypical ideas, but they're having a disfluency. That's the general term. So stammering is really just the word that everywhere else except the US uses to talk about stuttering, but otherwise no difference. It's really just a cultural language thing. So anyway, so what stuttering is a it's a characteristic of someone who has like disfluencies in their speech, where they might repeat a word like that. They might prolong a word, the sound gets stretched out, or they might have a block, like the sound gets fully stuck. So stuttering can look different depending on the moment. So someone who stutters mostly has like repetitions can still have a moment where they block, or a day where they block. So it doesn't mean that that's like your stuttering pattern necessarily. You tend to have like a pattern that is consistent for you, but it can vary within a day, within a person, within a moment, within a period of time. For most people who stutter, all of those kind of characteristics are present within their stuttering pattern. So another thing is that when someone is experiencing a stuttering moment, there's a physical loss of control of their speech. And so what happens when humans lose control, or they don't have control, is they try to gain control back. And so how that looks for someone who stutters, who's physically lost control of their speech, like the word is in their mind, but it's like lost control of their voice, basically. They try to gain that back, and that presents as like a lot of tension in your body, because that's what you have control over. And so that someone who stutters in a moment of stuttering, they might have a lot of physical tension, which, as someone who's not exposed to stuttering, can be challenging to listen to or to see. And so for parents, I work with all ages of kids and adults who stutter, but especially for parents watching their kids struggle and having like a lot of stuttering where it looks like that, where it's like feels really kind of painful. It can be hard. And so the thing I tell parents is like, yes, it sucks. Like, it doesn't feel good to have tension, but it's also not really painful. It's just a sign that they're struggling against that moment of stuttering. It's also different than having a tic. Really commonly misidentified as having like Tourette's or tic disorders. There is a huge overlap between Tourette's and tic disorders and stuttering, but they're not always like having a physical tension or having a moment where you have like what's called a secondary, where you physically use your body to get through a moment of stuttering. It's not the same as having a tic. So just a little nuance there. So stuttering happens at the level of speech execution. So somebody knows what they want to say. They have all their ideas in their mind. They organize their thoughts, and they are able to express their ideas at the language level of communication, but they have a difficult time physically saying it, getting it out. So that's experienced as a loss of control. So that loss of control can be so challenging for someone who stutters that they actually will describe it as feeling like they're drowning, or like they're suffocating. Like, it can be like a really extreme feeling. It can be really hard to deal with. So for a lot of stutterers, there's a component of actually dissociating during a moment of stuttering. For some, this just presents as like kind of a time perception. Like we all have those little moments where like we're kind of feeling nervous. Like when we were waiting for questions, like I I don't have a good perception of how long that time is because I'm feeling anxious. And so it feels longer than it actually is. And that's exactly how it is for people who stutter. If you ask someone, I love doing this with my clients because it really does help them to like put things in perspective. If you ask them like, how long do you think you just had that moment of stuttering for? They're all very wrong. So they'll say like, oh, that moment was horrible. I stuttered for like 30 seconds or I stuttered for 60 seconds. And I'll time them like to show them like, no, you stuttered for 5 seconds. Like that's how big of a difference it actually can be. So there's definitely that component of kind of like, just it's so unpleasant. It can really impact your ability to stay present with your body. So I have one client that like, and this happens not just with this client, but like, it's just a good example. One client who talks about how he fully feels dissociated from his body, where he's like looking over, it feels like he's looking over and watching himself in a moment of stuttering. Or like he'll have a presentation and he'll walk away just sweating, like has to change his clothes, like sweating so much, physiologically responding to the moment of stuttering. But when I asked him like, oh, were you feeling anxious? Like, what were you noticing? What were you feeling? What were you thinking? He's like, I was totally fine. Like, I don't understand why I'm having such a physiological response. But then when we explored it, he's not present at all in his body. And so that dissociation can be pretty significant. Even just like, think about like how often that happens for someone who stutters because they're talking all the time. And so it can be a pretty significant impact. So what is stuttering like from a causation type level? So it's not caused by anxiety, which is a really common myth. It is neurophysiological. If you ever want to talk about that, I am a total nerd about talking about the neurophysiology of stuttering. My master's thesis was like looking at like brain imaging. So cool. But basically is like our brains work inherently differently. For speaking especially. Probably for other things, there's like little research on like attention and stuff like that. Really high overlap between other disabilities like ADHD, especially ADHD, a little bit autism, like Tourette's for sure, just other disabilities in general. Yeah, so it's neurophysiological. So the way our brain is structured and then the way the execution of speaking at the neurological level is different. So specifically, we use more of our right hemisphere instead of our left hemisphere, which is where language and speech is typically exclusively organized. What's cool is that we actually use more of our brain, which I think has benefits. I think there's like some evidence that people who stutter have like a lot of creativity and creative thinking and stuff like that. But we're also using just more of our brain to speak. So that kind of goes with that. Anxiety is not the cause, but let me tell you why, some of the reasons why I think this is like so deeply perpetuated in our society. So anxiety does make stuttering happen more and happen more significantly. Like someone experiences more tension, someone experiences a longer moment of stuttering when they're anxious. Not everyone. For some people who have like a different way of dealing with their stuttering, they might actually stutter less when they're feeling nervous. That actually happens for me. If I'm feeling like I have to perform, I'll stutter less usually. But for a lot of people, it is the case. Also, when people who don't stutter, fluent speakers, have moments of disfluency, they usually do it when they're anxious. And so if that's the norm and that's the like position of power when talking about things, then it's going to get perpetuated. If 99% of people, it's only 1% of the population that stutters, 99% of people don't stutter, then that's going to be their perspective is when I, as a fluent speaker, not me, but when someone as a fluent speaker stutters, they are anxious. Therefore, when someone who stutters, they must be anxious. Not true. But it's also like, it's easy to see how that is perpetuated as a myth in our society. So quick thing, fluency is just the smoothness of someone's speech. So stuttering is a fluency disability. I don't like talking about using that word. Like people talk about stuttering, the area of stuttering as like an area of fluency within speech therapy. And it really bothers me because that is situated in the preference being fluency instead of the preference being someone speaking with a stutter. But that's what fluency means just as a term. What's interesting about stuttering is that someone who stutters has a lot of fluent speech. They're not stuttering on every word for the most part. And so stuttering is really variable, both within a moment, within a day, within a period. So that can be really confusing for a lot of people who stutter and for people listening to someone who stutters. Because on a specific day, and this is why like doing like assessments that look at someone's like severity, overt severity, are really kind of meaningless, because someone who stutters might have one day where they stutter very little, and then the next day they might stutter a lot. And that doesn't mean anything really. It just means that their brain is a brain and it's variable. Our brains are variable. We experience things variably. And so stuttering presents that way. But it can be hard for someone who stutters because they're trying to make meaning of that and have control of their stuttering when really it's just how it is. What's interesting is that there's actually an inverse correlation between overt severity. So there is like severity measures that we can look at. Someone who stutters does typically have a pattern of how much they stutter. Like we use mild, moderate, severe, very severe categories to talk about how often someone stutters, how severely struggled they can be. And so there's actually an inverse correlation between how much someone stutters physically and how much it bothers them, which is really interesting. So yeah, so getting into that, there's a pattern of stuttering called covert stuttering. So that's where someone hides their stuttering as their natural reaction to their stuttering. Well, when I say natural, I mean their learned reaction to their stuttering, because people don't start stuttering at 3 years old and try to hide their stuttering. Like there's a reason people do that. It's because of how people react to them, how they feel bad about their stuttering. And so for people who covertly stutter, actually, they tend to be more emotionally impacted by their stuttering. And we have assessments that can look at that, can show that. One thing I like is that in the literature originally, when they first talked about covert stuttering, they called it interiorized stuttering. Because just because someone's not overtly stuttering, that doesn't mean they're not stuttering. It just means that they're masking it, that they're feeling the tension, they're feeling the anticipation, they're feeling the stuttering moment, and they're doing everything in their power to avoid it, to hide it, to mask it. And so it is, just because you don't see it doesn't mean it's not impacting them. Which gets into the next slide, because we, unfortunately, apparently speech therapists love icebergs as analogies. I saw these slides and I saw Kristen's slides. She did them first. And she had an iceberg, and I'm like, well, I always use an iceberg. Like, what am I going to do? I'm going to copy her iceberg. But you know, it is a good analogy, because you only see the tip of the iceberg with stuttering. You only see when someone's physically stuttering. You don't see how they feel in that moment. You don't see the anxiety or the fear, the embarrassment, the shame, like the denial of what's happening, the like hopelessness, like isolation. Like there's just significant feelings that someone is going through in a moment of stuttering, and also just as a person who stutters. That is, most people don't see it all. So I see a question in the chat. I haven't read it, and so I don't know if I should pause or if I might get to it. I'm not sure.
Yeah, it's just my question, but you might get to it, so we can do it after when you finish.
Okay, perfect. So how do you do stuttering therapy? So the focus is always on participation, just with all of these areas. It's also on confidence, comfort, and effective communication without requiring someone to talk in a different way. So someone can be an effective communicator and stutter, full stop. In the field originally, well, in our fields currently still, there's a lot of people not doing that. Stuttering is actually the area of speech therapy that speech therapists say they feel the least comfortable in. And so unfortunately, there is a lot of harm in speech therapy to people who stutter. The whole reason I'm a speech therapist is because I wanted to give people a different experience than I had. And I almost didn't become a speech therapist because there is a ton of discrimination in this field for speech therapists who stutter. It was a very hard journey for me to get here. And it's ridiculous. And it should not happen, but it still happens this day. There's thankfully a lot of shift away from it, but there's, in the history of our field, we have been telling people you need to mask your stuttering in order to be an effective communicator. You need to mask your stuttering so that you don't make people uncomfortable, so that you can do all the things you want to do in your life. Otherwise, you can't do them if you stutter. And that's put people who stutter in a bind, because the reality is you can't make yourself fluent. If your brain stutters, you can't be fluent. Like, you can look smoother, you can sound smoother, but it's not without a lot of effort and a lot of stress. And it's not the same. Like, the fluency strategies, there's like a whole bunch of them that people have taught people who stutter. And if I use them, I might sound really fluent, but it sounds really odd. And I don't want to talk like this. Like, those are the strategies. Like, so there's a lot of debate in our field of like people are like, oh, if you accept your stuttering, then you can't, like, you're just giving up. And that's just so not true what it is. Like, that's not how it is. Like, you don't have to choose acceptance or like masking your stuttering. And also, this idea that you have a choice between like fluency and stuttering is just a false choice. And so I think one of the biggest things that speech therapists should know, and anyone who understands, who wants to support somebody who stutters, is that choosing between, do you want to talk more fluently, and choosing between stuttering is a very complicated question. Because when you ask anyone who stutters that question, they're going to say, I want to be more fluent. But they don't, like, that's not informed consent if you're not telling them, like, okay, well, there's all of this physical, emotional, and cognitive effort that comes from masking your stuttering. And so, like, when you tell people kind of the reality of what is like likely to happen, they'll say, like, I don't want to do that. And so I think that's a really important thing to keep thinking about. So what do we work on? Since I don't work on fluency at all. I don't work on making someone more fluent. I think it's encouraging masking. I think it's encouraging internalized ableism. Like, and so what we do is we uncover and dismantle those internalized ableist views, and I like to call stutter phobia. Other people use this term too. Oh, I see the question. Sorry, I'm gonna finish the slide, then I'll go to the question. Yeah, and so we kind of work through those, like understanding how someone is impacted by their stuttering and how they feel about it, but also understanding how their, like, the views in society and the reactions people have had to them impact their ability to want to stutter, their ability to want to talk even. And so we help them understand that and then kind of try to dismantle that. We also can work on struggle. Like, if someone is stuttering and they're really having a lot of physical struggle, that shows that they're bothered by their stuttering and they're trying to hold their stuttering back. Like, if they're stuttering in a really like struggled way, like, we can help work through making that easier. Absolutely. We can make stuttering more comfortable. We can't make someone not stutter, but we can make stuttering more comfortable. Absolutely. The question is a very easy question. The question is, you can't stutter if you're saying, interestingly, yeah, that's very true. So again, the brain neurophysiological thing, like singing, it happens in the right hemisphere for the most part, because it's like the creative parts of your brain. And so those parts of our brain aren't impacted by stuttering. There's been very interesting adaptations of that. Our field has done some really weird things with people who stutter as they try to understand the phenomenon of stuttering, because there's a lot of phenomenon. You don't stutter if you whisper. You don't stutter if you change your voice, if you like talk in a character accent or a character voice. Unfortunately, it's not long term, because if you sang all the time, which no one does, but probably you would stutter actually, because what happens is that anything that changes the way our brain hears our speech temporarily makes us stutter less, because it changes like our feed forward loop. I won't get into it. It's like really complicated, but I'm happy to talk about it another day. But it changes your brain temporarily. The thing is, your brain's really good at adapting, and so once it adapts, you start stuttering again. So you don't stutter if you whisper, but a lot of kids who are really anxious about stuttering will figure that out, little kids, and they'll start whispering all the time. And they'll stutter when they whisper all the time because their brain adapts to that. And so for me, I hid my stuttering all my life. I never felt like it was safe to stutter. So I talked in these different accents and character voices. And anytime I used one for too long, I would start stuttering. Then I have to switch to another. It sucked. It felt very inauthentic. Oops. The next question. Oh, that's a fun one.
I wanted to go back really quickly, especially as you're talking about changing voice. One of the things that I put in there is I'm curious if you've ever worked with folks at the intersection of like neurodivergence, like autism, as well as covert stuttering and gender dysphoria that are seeking voice training, but have, that covert stuttering. And I guess I'm just curious, yeah, if you've worked with folks at the intersection and like on techniques you utilize. I hear a lot of this here. But especially given just the changing of the voice intentional.
Yeah, that's a really good question. It's something I think about a lot because I do gender affirming voice therapy, and I like doing that. And so I think about this of like, am I doing this? Am I teaching someone to do what I tell people who stutter not to do? Like, how do I work through this? How I feel? And here's how I've landed. Like when someone is changing their voice to match their gender expression, they are embodying what feels authentic to their communication and to their expression of their identity. When someone is masking their stuttering and talking in a different voice to mask their stuttering, that is not coming from a place of authenticity. That's coming from a place of masking, of fear, of trauma, of anxiety. And also, when someone works on a voice for voice therapy, like that becomes their voice and it feels good to them. When someone changes their voice to avoid stuttering, eventually they stutter in that voice and then they want to change their voice again. So there's not authenticity associated with it. And so I do work with clients who have both. And it's never been an issue because it's just so different. Like it's all about your intentionality and how it feels. Like all the work we're doing with stuttering, with voice therapy, with most of this stuff is helping someone to express their identity in an authentic way and feel like connected to their authenticity. And for someone who stutters, their authenticity is that they stutter, like they have a stuttering voice. So I think that talked about your gender piece. Did that answer your question?
Yes, thank you. And then our other kind of question request is that you might get to it. But Bobby Joe said that they'd love a resource that they could share with a parent of a stutterer who they believe can benefit from understanding more about what an affirming view on stuttering and speech therapy looks like. They say, I think they are simply missing some basic education on fully understanding stuttering so that they can have realistic expectations of speech therapy.
Yeah, that is a really great question. And there is just there's so much misinformation and that's so challenging. It's also just such a disservice to parents and to adults seeking therapy. I can send some resources. There's some resources. There's not one amazing resource that I love. It's such a big area, but I think finding a speech therapist who's specialized in stuttering and is affirming of stuttering is really essential because there's just a variety of ways that speech therapists approach stuttering. No, there's not. There's two ways of how speech therapists approach stuttering. They either teach them to master stuttering or they don't and they do other things, but most speech therapists don't have comfort working in this area. And so I think they can grow comfort, but you have to do a lot of work to really be not doing harm. I don't know if I have a really good question. I don't have an easy answer to that question. But there are really great resources, even just free resources. I lead a support group in the community for kids and teens who stutter, just to connect with each other. And it's called the National Stuttering Association. There's what's great is the stuttering community is very active. Even though it's only 1% of the population, 5% of kids, it's like a really strong community. So there's a lot of like support people can get through kind of nonprofits and stuff that it's like accessible. So I'd recommend like maybe starting there. So there's National Stuttering Association, there's Friends, an association of young people who stutter. I can send like a resource list. So, okay. So I feel like I've covered some of these. Oh, wait to this slide. Okay, so some approaches for stuttering therapy. I'll just go through this really quick. So from like a kind of struggle and like physical approach to stuttering, the approach that I like to use, that's I think the most affirming, is called avoidance reduction therapy for stuttering. And so the goal is just to take the avoidance behaviors in someone's speech, so the ways that they're struggling against their stuttering, the ways that they're avoiding their stuttering, and kind of like breaking them down so that they don't have as much physical struggle in their speech and they can stutter more comfortably and more openly. And they can speak authentically without masking. So there are ways to kind of physically work on that. And then there's just a lot of counseling. Like stuttering therapy is mostly counseling. And so some approaches that lend really easily to stuttering therapy are like CBT and ACT, and mindfulness, helping someone cope with a moment of stuttering. Solution-focused brief therapy, I use a little bit. I just like to ask people the magic pill question. I'm like, what if I had a magic wand or a magic pill and I could take away your stuttering? That's a great question, because then it's like, okay, here's all the things you want to do in your life. Awesome. Let's go do those things. Like, who cares if you stutter? Like, obviously you have to work through how they feel about that. But you can still, that's like a great guiding question for like, what do you want to do more in your life? Somatic approaches help someone feel good in their body. EFT tapping is really interesting because it helps with like kind of gentle exposure therapy to like be able to sit with really uncomfortable emotions and uncomfortable beliefs that you hold. IFS is also really awesome, especially for covert stuttering, to help people take off, like realize their parts and the ways they're trying to protect themselves because they're afraid of stuttering. So some of the goals: understanding stuttering, understanding yourself, advocacy, asking for accommodations, and then helping someone like actually go through a grieving process to realize like they're going to stutter. Like if you're past the age of 7, like there's a lot of little kids who start stuttering and they stop stuttering, and it's probably because their brains are inherently different. Like with or without speech therapy, a lot of little kids stop stuttering. Who knows? We don't really know why. But if someone's past the age of 7, they're like almost certainly going to keep stuttering. So people have to grieve what their expectations of their speech and themselves are. And so I think we have to be part of that process. As I said, we have to uncover and explore the negative attitudes and beliefs about stuttering, about their communication, about themselves, because they develop an identity of with their experience of stuttering. We also just have to create safety to stutter. There's a lot of parallels between PTSD and stuttering, a lot of ways that stuttering can be traumatic. And so we have to create emotional safety. So some takeaways. As a related professional, not a speech therapist, it's really important just to educate yourself about stuttering, and be open to learning from your client, because everyone's experience with stuttering is a little bit different. How you listen to someone is important too. Like you just want to be patient and listen comfortably, as much as you can. You're probably going to be uncomfortable when you first experience someone stuttering, and that's okay. Research shows that like you actually have a physiological response when you first hear someone stuttering, but you adapt to that really quickly. And so you just get comfortable listening to someone's specific stuttering pattern. But just try to have natural communication. Like treat them as if they're someone who doesn't stutter. It seems obvious, but unfortunately people don't do that. Also, don't finish our sentences. It's really annoying. Also, don't assume someone's stuttering because they're comfortable or they're uncomfortable or whatever. Everyone's experience is different. And so you might be able to assume something, you might not, because stuttering is variable. Yeah, so as mental health therapists, I think it's really helpful to work in combination with a speech therapist and mental health therapist, because there is a lot of trauma that comes from stuttering. There can be, for sure. And so working through that absolutely can be your scope of practice. And you can work on some of these attitudes and beliefs. Like I've been in speech therapy before. I've also been in mental health therapy before. And both of my therapists have worked on similar things, like from different lenses. And so it can be really helpful for a mental health therapist to understand stuttering and actually be able to like work through some of this stuff too. Even if it's not as directly as we are, you're still seeing the person holistically. Okay, so shifting away from stuttering, there's two other kind of areas of fluency. I shouldn't use quotes. I just don't like the word fluency, but that impacts someone's fluency. And so there's cluttering. So this is one of the things that if you hear someone's speech and you don't think they stutter, but they kind of sound like they stutter, you don't think they have like an articulation disability, but they kind of sound like they do, they probably have a clutter. So it's a little bit, it's really under, there's a lot of there's not a lot of education about it. But it's where someone talks really quickly, and it kind of is hard to understand them. It's a little bit uneven, like inconsistent, like bursts of speech that is quick and then not as fast. So it can impact someone's intelligibility. Someone might have disfluencies in their speech, but it's not stuttering. They don't lose control of their speech. Also, it can impact expressive language, cognition and thought organization, as well as social language and writing. So someone's like both their like physical writing, like they have like messy handwriting, and also their ability to organize writing samples. So that's a big, like if you see that a lot of times, like that's the first sign of someone clutters. There also can be social emotional impacts, not because they're really aware of their speech all that much. Like they usually don't know they're talking quickly, which is really frustrating, but because people react negatively. So that's cluttering. We can talk about, I'm happy to I think it's one of those things that someone presents, like I have this interesting client and I don't know what's going on. And as you listen to them, it's often cluttering because it's just something people don't often are not exposed to. The other thing is atypical fluencies. So I hate this word, but it's a version of stuttering that's not stuttering. So someone doesn't lose control of their speech, but it sounds similar and it's in the same category right now. But it's where someone has like the word finding and language organization pieces of talking are challenging. And so they kind of almost use disfluencies to kind of buy time as they formulate their language. But they don't necessarily even realize they're doing that. So there's not always awareness that their speech sounds different. But how it presents is someone says a disfluency at the end of a word in the middle of a word. So like instead of saying like store, they'll be like store or they'll be like or store. A lot of times they're in like audible inhalations. I guarantee you, not guarantee, but likely if you work with neurodivergent folks, you have seen this pattern of stuttering. Yeah, someone's like, I do this. Yeah. And it's awesome. Like, it's just something that is like a different way of talking, but it's often like people are like, what is that stuttering? Is that not? So it's a little bit different. It's almost exclusively, if not exclusively seen in people who are neurodivergent. And so that's what that is. We can work if it bothers someone, or if like there's a language or cognition piece associated with it, we can work on that and help someone to find their words like more quickly or organize their language more easily if that bothers them. And so that's when we would like work with someone, but a lot of people do that. And it's just how they speak.
I feel like, yeah, we didn't like practice like the timing of this with questions. And so our timing is a little bit off from what we expected.
Okay.
No problem. I just really quickly, do you have a sense of maybe how much longer or how many slides that you have? I want to give you all the time and space, and we also have one consult today. And so usually when we have a consult, we give them at least 20 minutes. So we could go until like 11:10. But that's only 6 minutes. So I just want to gauge where you all are at.
Yeah, I mean, we can go through this faster. I think we definitely covered our areas of special interest. And then at this point, everything else is all the things that speech therapy can do and how we do them, and just faster.
Go ahead.
So we focus on language. So we support a bunch of different aspects of communication, including how language is learned and used. So there's a couple different ways to learn language. There's Gestalt language processing, where they learn language in whole phrases tied to experiences rather than starting with like single words. And this is different than analytic development, which builds language word by word. Gestalt learners start with full scripts and then they're later broken down and recombined. And then under the speech therapy umbrella, we also use AAC, so augmentative and alternative communication, like the iPads, the pictures. And then we just want to work on and remember that language isn't just about words. It's like tone, rhythm, gestures, emotional regulation also plays a big role. And then our goal under this language umbrella is to support all forms of just meaningful expression. So then another area is executive function. So this is just referring to the skills we use to plan, initiate, and participate in meaningful activities. So we support this by teaching someone to finish tasks using like visual external supports, talk about flexibility and co-regulation so they feel safe and supported doing what matters to them. And then many neurodivergent people also they mask. And so we're trying to talk about and navigate ways that they can use those executive function tools and not have to mask. And so we want to truly support and create an environment where people don't feel pressure to mask, spaces where stimming, silence, extra processing time, and indirect communication are welcomed and valid and respected as ways to be.
Okay, so voice therapy, I actually already talked about this a fair amount. So, but neurodiversity affirming voice therapy is basically helping someone to embody their authentic voice. And so that really plays into gender affirming voice therapy. There's also kind of a medical side of voice therapy that we can work on. And so like helping someone to have reduce the physical strain in their voice. So like through like vocal hygiene, or reducing kind of like abuse and misuse of your voice, just so someone's voice feels good to them. Basically, it's all about feeling good in your body, like physically, and being able to like embody like a voice that feels authentic to you. So that's what voice therapy does.
And so this is like the social pragmatics and prosody side. So often we use language socially, and this includes prosody, which includes rhythm, stress, intonation of speech. So in a neurodiversity affirming approach, our focus isn't making someone sound or act more typical. It's instead we center connection, clarity, and authentic self-expression. So in supporting pragmatics, we're not teaching social scripts or rules to follow. We're helping individuals build tools that support connection, like repairing misunderstanding, self-advocacy, communicating in ways that feel natural to them. We also recognize things like empathy or playfulness may look different for each person, and that's valid. With prosody, we're not trying to fix monotone speech or unique speaking patterns. We only want to work on aspects like pitch or volume if the person wants that support, such as being like, so they're able to be understood, and it also supports self-regulation. And so then we also support those with selective mutism. So our main goal as speech therapists is to create like a safe, low-pressure environment where communication can happen naturally. We want to honor all forms of communication, whether that's speaking, using gestures, writing, or AAC, and then to model these different ways of communicating ourselves. So overall, we just want to collaborate and make sure that they feel safe. And the goal isn't to mask, but to help each person communicate in a way that feels good and effective to them.
Okay, and then articulation is like what people think of as speech therapists, small amount of what we do. But if we are working on articulation, it should be if a client wants to. Like, I think the shift needs to be away from telling someone the way they sound or the way their sound are wrong. And that's what a lot of speech therapists have done in the past. But if you're doing it in a neurodiversity affirming way, you know, it's recognizing that someone's sound might sound different. And it might impact their intelligibility. It might impact how hard it is to understand them. It might impact their ability to engage because they're nervous about being misunderstood. And that's what we can support, is help. You can make your sounds different. Like, that is something that can change. But that's all it is. It's you're changing the sound. You're talking in a different way. But it should be with buy-in from that person. And then we also support apraxia, which is an area of like speech motor planning, where like someone's motor plans are like difficult to be executed. And so we can help support increasing their motor plans so they can say what they want to say. So that's really our presentation. We'll skip the summary slide. So you can definitely tell what we are passionate about. We're like, yeah, here's other areas of speech therapy. But if you have questions for us about other areas, we're happy to talk about them as well.
Thank you all so much. This was absolutely incredible. I feel so much more equipped to like even identify things that I hadn't before. So this is incredible. If anybody has any questions for them, y'all are welcome to always email admin and then we can forward them along if that feels okay to you. If it's not like a huge, like long specific question about like a specific client. But now we're going to transition into having our consult. So I'm going to pause the recording here.